Good morning, and thank you, Dr. Rashman and AIOS APO for giving me the opportunity to be here. I'll be talking on horizontal diplopia, and unfortunately, I do not have any conflict of interest. So the question is, we'll just start on a bit of introduction because, like, I'm going first. So whenever you have a patient who comes with diplopia, please clarify. Is it really diplopia? Sometimes, even macular issues and the patient has a little hazy vision in one eye, which is kind of overlapping with the other eye. The patient can say that it's diplopia, or very commonly an anterior segment person will say, hey, it is diplopia and it's his job, it's not my job at all. Same early keratoconus, refractive errors uncorrected. So need to confirm that it is double vision. You cover either eye, make sure that he knows that the quality of the image is the same and it is really diplopia. So you know that now it is diplopia. The next question comes, is it monocular or binocular? Again, a lot of patients come, especially with multifocals now in one eye, or a decentered IOL, or again, uncorrected astigmatism, or early keratoconus, again, who may have a monocular diplopia, but again refer to you for diplopia because you say diplopia and it's your job now, nobody else's. So you need to confirm whether it's monocular or binocular. If it's binocular, the next question comes whether it's transient or persistent. And then once you know it's persistent, you start thinking of the various diagnoses that you're going to have, restrictive, paralytic, which could be mono or polyneuropathy, and these things we'll be discussing during the course of the day. So monocular, you cover either eye, and if it goes, you know that it is monocular diplopia, and essentially not your job, at least not as a neuro-ophthalmologist. So there are a whole lot of causes for monocular diplopia that I mean, like needs to be identified by a good clinical exam of the eye. Binocular diplopia, so once you know it's binocular diplopia, it's a whole lot of various causes that are there, and that of course we'll be discussing in the various presentations. Based on the presentations, we'll be able to divide them into its various conditions. So I'll just start off with the overview. So patient has transient diplopia, worry about variability. So is it variable? Is it during the time of the day? Is it related to any? So is it related to the time of the day? Myasthenia. Is it related to getting tired in the evening or after long hours of near work? Is it a phoria that's breaking up? Is it when he's reading and he always gets it? Has he had a recent pair of glasses? So are they decentered glasses? Is the near segment causing a little bit of a tilt in the spectacles, so causing diplopia? When he's going down, is he looking through one part through his distance correction and one part through his intermediate correction in a progressive lens? So these are all very common causes, not easily picked up. So ask if he's recently got his glasses changed. Migraine, myokemia, multiple sclerosis, raised ICT. So all these are again raised ICT. Usually is going to have consistent diplopia, but sometimes it gets better as the pressure comes down. And again, when you have variable diplopia, always think and consider and worry about myasthenia. It's rare to have myasthenia without ptosis, but you can have it. This patient had horizontal as well as vertical diplopia. Again, the dictum for myasthenia is, if you do not understand the type of squint it is, think of myasthenia, because it will never follow a single pattern of a nerve involvement. So it's not like classically you can localize it's the third nerve, fourth nerve, sixth nerve. It's not multiple partial third and sixth nerve. So you have all lot of particularly both eyes getting involved. So if you don't understand, start working on myasthenia. Diplopia, ICE test is very good if you have ptosis. If you don't have ptosis, ICE test has very low sensitivity because the cooling cannot go as far back as the junction of the recti. So there it's a challenge, but you can try. Otherwise, a tensilon test in the OT is a very, very effective one. So you know that it's persistent diplopia. You have restrictive causes and paralytic. Restrictive causes come to us fairly frequently. Thyroid is a very important problem. Usually we think of thyroid like this, prominent eyeballs, particularly elevation deficit. But remember, among the earliest problems a thyroid patient will come with is dry eye and convergence insufficiency. These are early complaints. An older patient comes with difficulty in near, blurring intermittently, see whether he has convergence insufficiency, and one of the causes of that may be the fact that he may have an early thyroid. So it's important. So near diplopia, so they may come with near occasional intermittent diplopia. Think of thyroid as one of the other possibilities. So this was a 35-year-old female with diplopia, with a little bit of redness temporarily on the lateral side with swelling. Localized congestion on the lateral conjunctiva. Now, the most important thing, this patient is complaining of diplopia. The most important thing that you need to see, a pointer, mil sakta hai kya? So the most important thing you need to see for is the deviation in primary gaze and the limitation of abduction that the patient has. This is showing that it's probably not a paralytic squint. So it's a recently acquired diplopia, but the deviation in primary gaze is nowhere near compared to the limitation that you are seeing here in abduction. In restrictive strabismus, this is what you will see. In paralytic strabismus, the limitation more or less is same for the, you can compare the both because the muscle is not working whether you're looking straight or you're looking in the direction of gaze. But in restrictive strabismus, the problem may occur only when you're looking in that direction. So this was a patient had localized cysticercosis of the lateral rectus. So again, you need to understand what is the clinical presentation, localize the lesion, and try doing investigation. So if you had thought this as a sixth nerve palsy, done an MRI brain without actually looking at the orbits, or they would have just missed it, you would have missed this diagnosis and thought about it. So that's the most important thing. We'll just go more detail into the paralytic strabismus. The most common purely horizontal would be a sixth nerve palsy. In the others, you're going to have vertical as well as possibly horizontal. So I'll restrict myself to purely horizontal diplopia. So this was, so in sixth nerve palsy, you have, of course, multiple causes, usually uncrossed diplopia, maximum separation of the double images in the direction of the action of the muscle. So muscle separation on the ipsilateral side. You have a whole lot of causes, most commonly ischemic in the older patients, viral sometimes in younger children. Never forget raised intracranial pressure. So any patient with diplopia, frankly, any patient, you should look at the fundus, but definitely indicated in this. MRI is indicated if there is, of course, disc edema. There are other neurological signs or symptoms in a young patient, of course. So less than 40, 45 in the absence of systemic disorders, which can give you a suspicion of a medical cause. Think of get an imaging done. There is an increase in symptoms, so you probably think it's a medical cause, it's an ischemic cause, but you follow up the patient closely, and he comes back with increase. And I have burnt my fingers thinking it's just a sixth nerve palsy, and later on we realize it's a tumor which is slowly enlarging, and the patient later developed multiple other signs, and of course non-resolving or worsening. So this was a young patient presented with sudden onset diplopia. You can see a little bit of abduction deficit on both sides, and he was complaining of diplopia on the sides. So fundus revealed significant papilledema, a raised intracranial pressure. You need to do an imaging to find out the cause. So there can be multiple causes for the same. The most important, IIH is the most commonly seen, either idiopathic or associated with venous sinus thrombosis, but often the pressures are very high by the time they are coming with abduction deficits. And the reason this happens is because of this. This is the double bend the sixth nerve is going through. So when there is raised intracranial pressure, there is a downshift to the midbrain, causing a little bit of stretch of the nerve, sixth nerve, as it goes through the subarachnoid space, and that can cause the lateral rectus underactions to present with. Again, here you see you have a patient post-traumatic coming with an abduction deficit. Why not sixth nerve palsy? The reason, as we discussed, look at the deviation in primary gaze. Look at the limitation of movement and look at the deviation in primary gaze. The diplopia is predominantly in this case. So this is probably a localized trauma to the orbit. You can see an imaging that was done. A CT is enough, then you don't need an MRI, and you can see a blowout fracture that is entrapping the medial rectus and preventing abduction. Something we've started seeing a lot more common is the diagnosis of acute comitant esotropia. Of course, we have a lot of classifications. The most important thing for you to remember, it can be associated with neurological signs, and you need to get an imaging done, particularly of the brainstem. That's the area where is the localizing. Again, we keep thinking MRI tells me everything, but please remember, you need to not only give the correct investigation, you need to tell the radiologist what or where you are looking for the lesion, because they'll do a full brain. The brain scan is like going through the entire globe, and you can't identify Delhi in a quick globe scan. So same, they're doing an imaging of the MRI of the brain. They need to localize for small lesions in the midbrain where an acute comitant esotropia lesion can be. So please specify what is the area of interest. And Arnold-Chiari malformations are very, very common in young children or young adults, and of course, there can be all kinds of lesions. The one thing that is, I mean, really not classically neuro-ophthalmology, but acute comitant esotropia, children presenting out post-COVID, this has been fairly common. We are seeing a lot of children presenting to us with acute comitant esotropia. I still haven't changed my investigative pattern. Obviously, look at the fundus. Get an imaging done. I still get an imaging done, although pickup for imaging has really now less than 10% or probably even lower. Earlier, it was almost like 90 to 100% pre-COVID. An acute comitant esotropia would come once in 3 months or 4 months, and we have all the residents sit and discuss and get the imaging and work on that. But now, young children, lot of near work, even adults are now coming with lot of near work acute comitant esotropia. The other thing to differentiate in acute comitant esotropia is to get a cycloplegic refraction done, because accommodative spasms are the other things, but usually they'll complain of blur along with that. But if the vision is good, there is full motility and an esotropia in primary gaze. Acute comitant esotropia, like I said, I still continue to do imaging for these patients. Just to run through few of the differentials, of course, this child would not complain of diplopia, but this has, I mean, sent as bilateral sixth nerve palsy. Please remember, you need to patch one eye, just make sure that it's not a palsy. So this was just a cross fixation, very commonly seen in infantile esotropia. Just as a differential, before you start worrying of congenital bilateral sixth nerve palsy is not a common thing to see, because just the two sixth nerve nuclei are not going to develop abnormally without any other insult. So, but of course, exceptions are there. The other differential is Duan. So a young child, look for palpable fissure narrowing, look for the abduction, look for the difference, as I talked about in the beginning, in the deviation in primary gaze and the abduction deficit. So these are signs and suggestions that this is not a sixth nerve palsy. Many of these children start getting so extensively investigated that like, you know, it's unfortunate. I'll quickly just show you one more cause of diplopia. This is an internuclear ophthalmoplegia. You can see the adduction deficit, and then you do a check for convergence, and you can see the convergence is well preserved, because the convergence passes through a different route, while the internuclear ophthalmoplegia is through the medial longitudinal fasciculus. And of course, you need to again image in the midbrain region to identify an internuclear ophthalmoplegia. Just one more patient showing diplopia, left-sided. The only important thing to note is, again, I'm treading on the footsteps of speakers who are following up. So abduction deficit, mild proptosis with a slight ptosis. You identify, you localize it to the orbital apex, a Tolosa Hunt. Post-steroids is good. So early management, just follow up, prisms, botulinum toxin for sixth nerve palsy, and of course, after 6 months, maybe you can think of surgery. Thank you very much for the opportunity.